So now we will have Dr. Mazen, please.
بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. How to deal with the unhappy patient after refractive surgery. First, we have to categorize the patient into less than 20/20 patient and unhappy 20/20 patient. As you see here, the unhappy less than 20/20 patient, either residual refractive error regression, major corneal irregularities, reduced vision due to other pathologies. While the unhappy 20/20 patient, refractive reasons and non-refractive reasons. We will go through these steps. First, with the unhappy less than 20/20 patient. Residual refractive error. We see that miscellaneous, a lot of reasons like miscalculations, wrong calibration of the machine, wrong input of refraction, especially in astigmatism. Sometimes the nurse may input plus instead of minus, or 180 instead of 180. So it's our responsibility as surgeon to double check before we start. And as I mentioned yesterday, you have to know the laser profile, how it works, in order to be able to recognize early if the ablation is correct or not. And if you are doing lens-based refractive surgery, then one of the reasons is miscalculation of the IOLs or wrong formulas that you have used. Okay. Now, can we say that any refractive error is significant? Well, this depends on the previous refractive error and the induced refractive error and the amount and axis. Sometimes if the axis is oblique or against the rule, the patient cannot tolerate it, while if it is with the rule and small, then the patient can tolerate it. Now, the loss of effect because of biomechanical changes after the operation or because of the epithelial remodeling. Sometimes nuclear sclerosis may develop later if the patient is diabetic, if the patient is taking medications. So the refractive error regression can be due to these causes. Major corneal irregularities that may develop after the treatment, like ectasia, small optical zone, steep and flat optical zone, and decentered optical zone. This is the problem when we convert Keynote to PowerPoint. Reduced vision due to other pathologies, cataract, of course, so we have to dilate the pupil properly and check the lens properly. Sometimes retinal or optic nerve diseases. So it's not only because the refractive surgery was not 100% successful. Corneal opacities like haze. Sometimes haze is very, very, very subtle, so sometimes we cannot recognize it with the very quick slit lamp examination. So you have to check the any corneal opacity. We come to the other one, which is the unhappy 20/20 patient. There are refractive reasons like small residual myopia affecting night vision, small residual hyperopia affecting near vision, small residual astigmatism, small corneal irregularities, and changes in the native high-order aberrations. Because if we treat native high-order aberrations with neuroadaptation, maybe we will convert it into new high-order aberrations that the patient cannot go with neuroadaptation with them. The non-refractive reasons, dry eye, think always of dry eye and treat the ocular surface properly. Sometimes the patient, when they come with 20/20 vision and unhappy, it's because they are presbyopic or early cataract, low contrast sensitivity. And as we know, all types of laser-based refractive surgery will reduce the contrast sensitivity. Inter-eye disparity. Sometimes one eye is 10/10 and the other eye is 12/10. So the patient starts suffering from the eye which is 10/10. And dysphotopsia, of course, after lens-based refractive surgery. Now, how to deal with those patients in general? First, we have to check everything, including the vision for distance, intermediate and near, potential visual acuity if the best correct visual acuity is below 20/20, contrast sensitivity, manifest refraction, and cycloplegic refraction. We have to do corneal tomography and topography if there is any corneal haziness, because tomography in this case will not be accurate. Total wavefront or corneal wavefront, if both, it would be better. And careful slit lamp biomicroscopy, including dilated fundus exam and crystalline lens exam. Dry eye workup, like the tear film breakup time, Schirmer, corneal sensation test, corneal staining, and checking the lid's closure, for example, lid contour, lid margin, if any meibomian gland dysfunction, blepharitis. General health and medications, like if the patient is taking any general medications or have diabetes, for example. Now, what is the roadmap? First, we have to exclude non-refractive causes like dry eye, corneal opacities, cataract, diabetes, medications, retinal and optic nerve diseases. Second, we have to understand patient's demand, because the patient may suffer only from near vision, may suffer from distance vision, may suffer from high order aberrations, low contrast sensitivity, inter-eye disparity. So understand which one of those the patient is suffering from. Third, give time for adaptation and stability. So wait for 3 to 6 months, unless it is really ectasia or there is a significant refractive error. So no way to wait in these two cases. Number 4, determine the indication of enhancement. So are you going to enhance for near vision or distance or treat high order aberrations? Of course, we cannot change low contrast, and usually we cannot reduce the vision in the one which is more than better. Number 5, choose the proper type for the patient, proper type of enhancement, because several types, and my colleagues, Dr. Mohammed Husni and Mohammed Shafiq, mentioned those types of enhancement over previous keratorefractive procedure, over previous intraocular implantation. So the ablation can be optimized, customized, and of course there are several types of enhancement after LASIK, after PRK, and after SMILE. But precautions for the haze, scarring, epithelial ingrowth, and refractive instability and ectasia, of course. Over previous intraocular lens implantation first, before you do this, differentiate between the refractive error and the dysphotopsia that the patient may suffer from. And of course, there are 3 types of dysphotopsia: the diffractive, the positive, and the negative. The diffractive, there is a problem with the point source of light. The positive, with oblique lights. The negative, there is a dark temporal shadow. Of course, I'm not going to go through how to treat the dysphotopsia because of the sake of time. So as a take-home message, classify the unhappy patient into 20/20 or less, understand patient's demands, give time for neural adaptation, and act with the least invasive intervention. Thank you very much.